Hello everyone, so welcome. Thank you very much for joining us, particularly on this hot and sticky evening. My name is Louise Halfpenny and I'm the Director of Communications. What we're going to do through this meeting is to have you on mute so that we can go through our presentation, and then at the end we will take a short pause and then there will be some questions. You are very welcome, please, to send your questions to me. So you will have the option to direct your chat to Louise Halfpenny. So if you can do that as we go through, we won't stop to answer them, but we will take a short break and then come back and answer them. You can send us questions afterwards and we will endeavour to get back to you next week after our second session with any answers. There is also further information on the website, and the most important thing to tell you now is that we are going to ask you to do some work with us, and there is a deadline, and that is midday on Wednesday the 1st of July. Next slide please, Helen. And just going on to the stakeholder reference group. So this is a forum, some new faces and some familiar faces. So good to have you all on board. We will listen to what you say. We might not be able to give everybody what they want. And we hope that you will want to stay involved with us. Once we're past the shortlisting phase, we will be working in more detail on some of our services and pathways, and you can be involved on a co-production style of working with us on issues like digital technology or access. Throughout the summer, we may ask you to complete surveys and we'll ask for your feedback. We'll tell you how we're using your feedback, and we might set up further sessions like this. And we will endeavour to produce short films, explainer films, to give you more information as we go through the outline business case process. There is a terms of reference on the website if you want to read a little bit more about the stakeholder reference group. And the purpose of today's session is to recap for those of you who have got a little bit of background knowledge, and to introduce the redevelopment programme to those of you who are new. We will set out the process over the coming months, and we will talk to you about your involvement and how you can help shape our appraisal framework. We are also talking to our staff here and to partners in other organisations, so quite a wide stakeholder feedback throughout the summer months. We will continue to grow this reference group as we have topics that we want to discuss with you. And your hosts for the session are Freddie Banks, Helen Brown, David Evans and Esther Moores. And I'm just going to hand over to Helen.
Thank you, Louise. So my name is Helen Brown. I'm the Deputy Chief Exec at West Herts Hospitals. I've been involved with this programme since I joined the Trust in 2014. I'm going to give you a very quick recap and latest news in relation to the redevelopment. So we've been working on this for a long time. It predates my joining the Trust. So back in the late early 2000s, let's call it, there was work done. But more recently, we developed a strategic outline case in 2017, setting out plans for redeveloping our hospitals. We submitted that to regulators for approval, but it wasn't ultimately approved. The feedback we received at that time was that the indicative cost of the redevelopment was more than could be afforded, and we were asked to look again and come back with options with a cost of no more than £350 million, which is broadly in line with our turnover as an organisation. So that work we undertook in 2018 with the SOC finally approved in July of 2019. And that set out plans for a redevelopment of emergency care services on the Watford site, I think a partial redevelopment, and some investment into Hemel Hempstead and St Albans hospitals to improve facilities on those sites. In September of 2019, we were named as one of the 6 trusts in the first wave of the Health Infrastructure Plan programme, with an indicative capital allocation of £400 million. So that was very positive news to be confirmed as a priority hospital for improvement in the first phase of the Health Infrastructure Plan. We have been talking to regulators since that date to progress the work that needs to be done to take us to outline business case, and we'll be telling you a bit more about that process today. But very recently, last week, we did receive some feedback from regulators confirming that we could include an option within the outline business case, which includes significantly more new build at Watford General Hospital for emergency care services, including replacing rather than refurbishing the main clinical block, with an estimated capital cost of about £590 million. That feedback we've had from regulators. They've been very keen to stress that there's no guarantee at this stage that that level of funding would be available, but they have confirmed that we can look at that option in the outline business case process. And I'm sure there will be questions later as well about other options that may or may not be included in the long list process. So I'm now going to hand over to Freddie, who is our clinical lead for the programme, and he's going to give you a bit of the vision and clinical context for the redevelopment.
Thank you very much, Helen. My name is Freddie Banks. I am a consultant surgeon, urologist at West Herts and also Associate Medical Director. The last 103 days since we've gone into lockdown with the COVID crisis have been quite extraordinary in my medical career, and it's really opened our eyes to transforming the way that we deliver care. I think it's also comprehensively shown as a consequence of the COVID crisis that this combined model that we have in the UK of emergency and elective care being delivered from the same centre simply doesn't work. And I think if you need proof of the solution to that, you just have to look at what the nation's response has been, which is in effect to create emergency hospitals, which are largely the NHS hospitals, and then create elective centres, and all of the private sector has been effectively commissioned to be the elective centre for the NHS. And Spar Bushy has in effect just become the elective surgical and some degrees diagnostic centre for West Herts. But it's also given us a fundamental rethink of how we deliver care, and we have been absolutely catapulted into a digital era. We effectively had a choice of delivering no care or delivering it to you over the telephone or online. And I think that's made us realise that we can actually deliver care not just closer to your home, but it will actually be in your home in future. But the segregation of emergency and elective service is absolutely going to be essential to this. And I think it's paramount that although these services are integral to each other, but they shouldn't impact on each other. So if you're coming in as an emergency, you should be able to get the scans, imaging and beds that you require, and it shouldn't be impacted on by elective patients. And similarly, vice versa. No elective patient should have their operation cancelled because an emergency patient took their bed last night. Next slide, please.
Oh, I've lost my cursor. There we go.
So if we deal with elective care, I think what is rapidly becoming obvious is that the model of care will be an initial consultation, which will almost certainly be either digital via Zoom, like we're using tonight, or over telephone. And then all of your investigations we will try and plan, hopefully all in a single day, in a single centre, so that you have a sort of one-hit wonder where everything is done in the same day. And hopefully we can actually get you to a point where you can get the results that very same day and see a doctor then at that point. If we can't actually get all those results to you on the same day, then hopefully we'll actually, instead of bringing you back up to hospital for results, we can deliver that to you online in the comfort of your own home. But we do need to have state-of-the-art diagnostics. Some of that is already being delivered in the community, and some of the simpler diagnostics will be delivered much closer to you at home through GP surgeries and diagnostics, and that's already happened. That's happened in orthopedics, that's happened in gynecology, and the CCG regionally have got the ultrasound service for most of the non-essential services. We very much hope, though, that patients will be empowered as well in a digital era where you can actually change your appointments. You should have access to your own notes. The GPs should also have an integrated service so that instead of waiting for letters to arrive from a hospital, no sooner have we written that letter, then it's available to you either through some form of patient portal, and your GP also gets exactly that same information, so there aren't time delays and it's all joined up. And that also links in with for the elderly population, so that we've got a much more integrated service through the community, so we're aware of what services people are accessing at home, and that also applies to mental health and paediatrics as well. The next slide, please, Helen. Now, emergency care. This has changed beyond belief in the 25 years that I've been a doctor. When I actually did my A&E job, which was about 24 years ago now, A&E departments, effectively one or two consultant departments with a handful of junior doctors in their second year out of medical school. And emergency care was effectively a sort of nuisance factor that you did alongside elective care with the hospital. We didn't really have any designated emergency time. It was just sort of squeezed in amongst all the elective care. If you look at how it has changed now, we have a department, probably, I'm not quite sure how many consultants we've got, but probably in excess of 10, 20 juniors. We have a completely segregated paediatric A&E. There is a paediatric A&E consultant, and it has changed absolutely beyond belief. And emergency care is now a huge, great specialty in itself, very multifaceted. And you just look at the way the demand has changed. When I was doing my A&E stint, anybody who was over 65 went pretty much straight to the geriatricians. And the general surgeons really wouldn't touch a patient over the age of 75. Now I have a minor celebration if I have a 75-year-old on my list, as he'll probably be the youngest patient on my list rather than the oldest. And the key thing to delivering emergency care is that you get access to the right team, you get the right investigations, and you have proper emergency teams looking after you. Your emergency admission shouldn't be an aside to elective work. It should be the beating heart of why you are actually in there. And we need to develop proper integrated assessments, units with all the right diagnostics and proper teams dedicated to delivering emergency care. Look at the next slide, please, Alan. To do that, we have absolutely got to have buildings. Our current A&E department was effectively designed for the service that I worked in 25 years ago, and it's simply not fit for purpose now. We need to have proper streaming, really good patient flow, designed to get patients into hospital well, get your examinations done, hopefully get you out of hospital. The aim is not to keep you in hospital. And we have got to, and I cannot stress this enough, got to have a building that is capable of delivering that flow of patients. And you just have to go back to the sort of the volume of patients that comes in. You know, at times in the peak times, we're getting 60 patients an hour coming in over several hours. You know, it is a massive logistical nightmare trying to just cope with that number of patients. When you do go into hospital, everything needs to be digitalised, and you should expect to have much greater privacy and dignity. And that we can deliver by single rooms. No patient should have to worry about going to the bathroom through a bay with their bum hanging out of one of those hospital gowns. You should be able to have that privacy ideally delivered in a single room. That gives you the reassurance of infection control. And from looking after you, we need to get teams of people together. That means having clinical adjacencies so that services that you need are co-located together in the same hospital. It shouldn't be a visiting service from another hospital or another part of the trust. One of the biggest problems of the NHS is staff. Maintaining and finding enough staff to actually man the diagnostics, man the nursing staff. And we need to build an environment that attracts people to come and work at West Herts. And when you come and work in West Herts, you need to be and feel supported both in your work by the environment and also from your a well-being perspective. And that is absolutely essential that we deliver that as part of the hospital refurbishment. So, thank you.
So Freddie, I think I'm picking up from you there, thank you. So I'm just going to give you a really brief overview of the whole process. So where are we now and what's it going to take to get us to construction? And this is all set out by the Treasury in something called the Green Book. So if any of you want a little bit of light bedtime reading, it's a very detailed guide to how these business case processes have to be done, and it is mandated, so we have to use this approach. It's a 3-stage model with a strategic outline case, an outline business case, and a full business case. We're at outline business case stage at the moment. We've just started that process. And the outline business case is a really critical part of the process because that's when you identify your preferred option. So you draw on work that was done at the strategic outline case stage. You look and see whether anything's changed, and you do the work to confirm the preferred option. You also do the very detailed design and planning work and make sure you're building the right hospital at the right size, and all the detail of exactly what goes where. When that's completed, you have to get that approved through the Department of Health, and then you move into the full business case stage, which is effectively you procure a construction partner, you do really detailed costings and really detailed delivery plans, and then finally at that point it goes through to a final approval by both the Department of Health and the Treasury, and you get permission to start building, hopefully. So that's an overview of the overall process. In terms of what that means for us and our timeline, sorry, this is quite a busy slide, but effectively the different colours show the different phases of work. We're in the green phase, which is 2020 to 2021, which is outline business case stage. I've already mentioned that a key part of that is identifying the preferred option, and that's really what we're going to be working with you on over the next 6 months. The first part of that is approving a short list of options that get more detailed appraisal. So that's going to be the focus between now and September, is agreeing the short list, and then from September through to early 2021 it will be doing the appraisal that then confirms the preferred option. There is more to the outline business case than just the option appraisal. There's a lot of detailed work, and we will talk to you about that in future sessions as well, and very much hope that some of you will help us with that more detailed work. Once we've got, so our target timeline at the moment is to try and complete all the work for the outline business case with approval of the outline business case in December 2021, so just before 22. And then we move into full business case process, subject to approval by the regulators. And then the full business case is a little bit quicker than that. We should be able to complete that in 12 months with an ambition to commence building work in 2023, and then a 2 to 3 year build programme from there. So that, in headline terms, is the process to get us from today through to construction starting. So I'm now going to hand over to Esther, who's going to talk you through what we want your particular input on today.
Thank you, Helen. So I will be talking about two areas for which we are really wanting to gain your input. So talking particularly about investment objectives and also essential criteria, and I'll explain what we mean by those as we go through. So first of all, thinking about investment objectives, these really list out what it is that we want to achieve as a result of the investment that we will be making. So if we move on to the next slide, you can see our headlines for our investment objectives, and we really want to have your feedback on these. The full set, full information behind them is available on the internet. But I think following on from a lot of what Freddie's already said, none of these will come as a surprise. We know that we really need to improve our emergency care infrastructure and services. As Freddie described, that separation between planned care and emergency care services that we talked about previously in our strategic outline case, as a result of recent experiences, that's really enforced why that's of value to the way that we work. There are so many opportunities to use digital technology better. So yes, we've had a real crash course in how we use technology such as Zoom over recent weeks, but there's much more that we could be doing by way of having our own sort of monitoring systems, both for patients and for the buildings and how we work, and also supporting use of technology and increasingly for self-monitoring. And that there are so many opportunities. It's more a case of deciding in which order we would want to do them with everything that we could be doing. The other element that is really important from a clinical perspective, which is, again, it alludes back to the comments that Freddie was making, is that medicine is getting increasingly specialised. Is, you know, in days gone by, you might come to see the general physician, the general orthopaedic surgeon, as opposed to now seeing the back specialist, the wrist specialist, the respiratory specialist. So we're really keen to make sure that where we have those really specialist teams, we're not dispersing them, and that you can come and have as much done in a single day because we've got the people that you need to see available. And then, of course, really importantly, what we do has to ensure that we're making good use of the taxpayers' money. So on to the next slide. One of the discussions that we had as part of our strategic outline case, when we had that funding threshold, was about where do we most need to invest. And for people who were involved at that time, you'll remember we had quite a discussion as to, is our priority to really invest in our emergency care facilities, or to create a new facility for planned care. And what came out of that was that we see the most vulnerable, the sickest, a high volume of West Herts patients for emergency care. And that really cannot wait. That's the most important area for investment. So we know that we want to prioritise investment in emergency care in an environment where we can't do everything because funding is, of course, limited, but we do need to improve emergency care as quickly as we can. That's not to say that planned care isn't still really important. It's just when we're looking at the relative priority, that was the decision making and the point that we reached out of our previous strategic outline case. So we would really like your feedback on those investment objectives, and over the course of the next few weeks there are other elements that we will be asking you to get involved in as well. So if we have a look at the next slide, you'll see that we've got today's stakeholder reference group, and we're running a similar session tomorrow at which we will be talking about our investment objectives, asking you to feed back to us by middle of next week. We're also wanting then at our next session with you to really talk through the clinical model and how we're approaching our long list of options. And then a further session will be planned around our long list appraisal. So that's just really to give you an overview as to what's coming next, as well as asking you for the feedback on our investment objectives and our essential criteria. So, essential criteria. These are a means of looking at the whole range of options that we have available to us, our long list of options, and deciding which ones of those we think really deserve further review and further analysis. So we want to start with a comprehensive list of the options that are available to us, but we won't, of course, want to take forward onto our shortlist things that actually aren't deliverable or aren't achievable, and we've got to make sure that they're things that meet those investment objectives that we just talked about. So the process at this point, the reason for having the essential criteria is that they help us rule out undeliverable options. So we've got proposed essential criteria, and you can see the headlines of them there. On the next slide, we can provide a little more detail to say, how do each of those essential criteria help us with our decision making? So when we talk about the fit with strategy, what we're saying here is we need to make sure that our options are in line with what we think is right for clinical services. They're in line with what our partner organisations in health and social care are also thinking, and also that they give us flexibility for the future. You know, as much as A&E care has developed in the last 20 years or so, or during the time of Freddie's career, we know that the way we deliver care in 20 years from now is something that we can't necessarily imagine. So we need to make sure that our buildings can adapt as clinical care does. I think the second essential criteria really speaks for itself. So everything that we do comes down to what's the experience for our patients and our families. So, you know, that one we take as read, that we are always trying to get that right and to improve on what we do. From a quality perspective, we need to make sure that we maintain patient safety, and some of those adjacencies between clinical services, that's really important that we get that right so that we can really maximise the quality of care that we deliver. And we want to know that patients can access our services, both, you know, from an emergency perspective when you absolutely need care quickly, and also for planned care when we're wanting to try to make sure that we do deliver care in your home, and when you come to visit that you get everything you need as far as we possibly can on that single day visit. Money, of course, is always a consideration, both by way of what we can spend on a building itself, but also what we can afford to continue to run as a building and as a system for healthcare. So we have to consider whether any options would be not only affordable from capital and an investment now in the buildings, but also can we continue to run that sort of facility into the future. And then finally, our essential criteria around deliverability is around, you know, will a particular site give us the size that we need to deliver the care? What does it mean for the infrastructure, and are there planning considerations? Can we move as quickly as we need to do? What does it do for our need to, and our desire to make improvements as quickly as we can for the whole of the West Herts population. So that's to give you a flavour of the definitions and to ask the question whether you think that explains well the criteria, and whether those definitions pass a general common sense check. So your task, which we're asking for your support with, is firstly those investment objectives that I started by talking through. Do you think they're right? And then do you think the essential criteria that I've just talked through will help us in that task of ruling out any options that we think might be undeliverable, and whether whatever your opinion is, whether it's yes or no, we really want to hear from you, and also to have any further comments. So if there's something that you think you would like to query, then it's really helpful for us to know why it is and what you might suggest instead. So hopefully that's covered the task ahead of us. So I'd like to explain today's session.
Sure. Thank you very much, Esther. So we've gone through the presentation now, and what we would like to do is to give you some time to ask us questions, and the questions that you have for us we're hoping would be around the presentation, and if you have questions about the task. We're not asking at this stage for you to have thought about the essential criteria and the investment objectives and to give us an answer in 5 minutes, but we want you to ask us any questions about the presentation, anything that hasn't been clear to you and anything that's not clear to you about the task. I have had a couple of questions through. If you have a question, it's through to me, Louise Halfpenny. We can hold the questions until 18:40, so for another 5 minutes, and then we will regroup at 5 to 7. So you've got a few more minutes to send any questions via the chat function to me, Louise Halfpenny. Keep your meeting running, don't leave the meeting, but by all means go and grab a cup of tea or a glass of water, and we'll be back with you at 5 to 7. Thank you. Raised. We have had quite a lot in, and apologies if we don't get to yours. We're saving all the questions. We're working up a revised frequently asked questions, which will address, we hope, many, if not all, of the points that you've raised. And we will probably leave a little bit longer when you do this tomorrow for people to ask questions, because most of them came in after the presentation. So obviously that's a learning point for us. So apologies if you felt rushed. There was a really interesting question about planned care. So I'm going to ask Freddie Banks to answer that question. And the question was, have we given up on planned care and has it all gone to Spire? So Freddie, if I can ask you to address that point, please.
We certainly haven't given up on it. Currently, it's very difficult with the practicalities and the regulations around COVID. So just to give you a taster of that, a patient has to very strictly self-isolate for 14 days prior to coming into surgery, and then have a swab to make sure that they haven't got coronavirus 3 days beforehand. So the logistics for a patient are very difficult, and from a doctor point of view, we are continuing to operate in full PPE gear. There is an extended period of time where a patient is recovered in theatre, so our throughput, unfortunately, at the moment is very, very slow. But we are working very hard to try and repatriate this to both Watford and St Albans. And I think my anticipation is that over the next 2 months, the arrangement will stop, and we will revert to in-house elective surgery. But at present, I think it's going to be at a rather slower capacity than we've been used to. So it's going to take quite a long while, I'm afraid, to get up to full speed with elective surgery, and that's a problem that is across the country rather than unique to West Herts.
Thank you, Freddie. Thank you. So I'm just going to pick up a couple of other questions before handing some questions over to Helen. And there was a question about the Green Book, because we know there's a Green Book used in pharmacy. This is a very different Green Book. It's the one from the Treasury, and it sets out the process that we must follow to go through the various stages of the business case. So it takes us through the strategic outline case, the outline business case where we are now, and the full business case. And this year, or this time round, it sets out a slightly different appraisal model, which we will share with you next time. And the other question I just wanted to answer before handing to Helen for some answers on other questions was around population forecasts. And the question was, are we planning to the financial budget that we might have from the government, and looking at that rather than the population forecasts? So the answer is no. We look at everything in the round. We will look at population forecasts. That's one of the things that we must do in an outline business case. So absolutely want to assure you that we will look at those population forecasts. So going on to some of the other questions, I will just pick up this one, which was about the first 20 minutes. I think there was somebody who missed the first 20 minutes and wondered if we had discussed investment per site. So just if you were that person, no, we didn't. We will look at financial details in much more depth later on. So Helen, I'd like, if you wouldn't mind, to address a question about the integrated care system and how it will be involved in the approval process.
So I'm actually going to ask David Evans from Herts Valley CCG to talk about commissioner approval and integrated care system approval. And then you can come back to me for the questions we've got around the options and particularly the greenfield options. David? We need to unmute you, David.
I think David's struggling to unmute himself. I think whether he's blocked.
Okay, you have to bear with us because we're all in different places and it's the first time we've run a webinar like this. So we'll come back to David and the integrated care system and commissioner approvals. I will pick up the questions that we've received. Quite financial envelope, and that's obviously changed, and that's new news today, as it were, and the greenfield options. So in terms of the discussion that we've had with the regulators and that position at the moment, they have said that we may consider an option which increases the investment into emergency care, and they've explicitly talked about an option that replaces the main clinical block at Watford. For those of you who were more involved in our strategic outline case, you'll know that with the £350 million limit, we were going to build a substantial new block at Watford, but we also needed to retain the existing Princess Michael of Kent building and refurbish it. We've had a number of discussions with regulators and debated really the disadvantages of retaining PMOK and refurbishing it versus the benefits of new clinical build. And at this stage, what they've said to us quite clearly, apologies, I'm struck by a tickly throat at just the wrong point. What they've said to us is that we can appraise options above the 350 million threshold, but that that isn't approval. of options. It isn't approval of funding above that level. So I'm having a hot flush. It's warm this evening, isn't it? So in relation to then what flexibility we've got, and whether or not that gives us flexibility to look at a whole new emergency care hospital on a new site, that hasn't been either ruled in or ruled out at this stage, either by the regulators or by ourselves. The process at outline business case stage gives us an opportunity to have another look. This long list process, taking us through to a shortlist process, will consider whether there are other options that we think are viable and would provide a good solution. The feedback that we have had from regulators, as I've said, is that the funding envelope currently does still stand at 400 million, but they're willing to let us consider other options in this process. It is all subject to approval through the department and the Treasury in due course, that they're very keen that the timeline of any options that we consider isn't significantly longer than the 2025-26 timeline that we've described. So in that context, we will, in this shortlist process, be having another look at new hospital, new site options. And for your information, just to say that we have commissioned a piece of work by Royal Free Property Group, who are supporting us with the technical elements of the business case, and also Montague Evans, who are, you know, a big professional services firms with expertise in this area, to review a small number of greenfield options and give us a professional perspective on the viability of those sites and the likely time frame to bring any of those sites into development as a hospital. So I'm sure we will come back to this issue a number of times over the next 2 and 3 months as we go through the long list to short list process, but that's the position as it currently stands.
I see that David has joined us, so I wonder if we can go back to the question. David, we had a question about the approval process. How will the integrated care system be involved in the approval process?
Thanks, Louise. Can everybody hear me? I think so.
Yes.
So thanks, Helen. I was able to unmute myself then, so thank you for letting me do that. So in terms of the ICS, so that's our integrated care system, and that is a collection of our partners across Hertfordshire and West Essex. They will need to have a view and provide that view to the CCG. So the CCG does have to formally sign off the outline business case, so that will be part of the process. The CCG is a partner in the integrated care system and will take feedback from that. I think that the key thing for the integrated care system will be taking into account the right hospital, the right size, the right patient pathways, and the ability of it to be delivered within that context. So what we expect is there to be a conversation between the CCG and its partners prior to a sign-off from the CCG when the outline business case is ready. So I think that covers it, Helen.
Thank you, David. Where do you want us to go next, Louise, in terms of questions?
There was one about whether or not we would consider private land. So perhaps if you could address that, either Helen or Esther.
Yes, I'll pick that up. So absolutely, we're not, when we talk about reviewing new site options, that is not limited to either NHS or public sector land. We have got a small number of sites, that most of which have been debated in the past, that we're having another look at, and they are all owned by different developers or Crown Estates, for example, so that it's not NHS and public sector land that we're considering.
Thank you. And can I ask you a question about the approval of PAH, so Princess Alexandra Hospital, and how that may affect our plans, how that might influence our plans.
Yes, so this is a slightly, this is a question that we often get asked, and obviously we do work with PAH because they're in the same system as us, and we are both going through the same process, so we're sharing learning and making sure we're keeping an eye on what each other's doing. Having said which, I'm not close to the discussions that PAH are having with regulators, but my best understanding as yet is that their plans are not approved. However, you know, I'm sure most people, or many people on the call today, will be aware that PAH are looking at a new hospital on a new site. That's their preferred option, and they are in a very detailed discussion with the Department of Health and NHS England to see whether that's either viable or affordable. But my understanding is that that is not at the approval stage yet, and just like us, they have to go through an outline business case process.
Thank you. And a further question, which is about our recent CQC report and whether it will drive decisions. I'm not sure if that's our decisions or regulated decisions, but perhaps you might like to just touch on the recent report, Helen.
I can touch on the report. Broadly, the most recent inspection showed some continued improvement, and many of our services are now rated good, although overall the trust is still rated requires improvement. We saw improvements in our rating for well-led and for effectiveness. I think in reality, the answer is no. The CQC report doesn't directly drive long-term strategic decisions around the way we organise services and the need for investment. The CQC is, however, clear that our current buildings and facilities are not fit for purpose and don't help us deliver good care. So they're very keen, as other partners are, to see improvements in the facilities. I think the fact that our well-led rating has improved to good is very helpful, because it will give regulators confidence that if they approve our proposals, the trust will be in a good position to then move on and deliver them. And it's not just about building a new hospital, although that is a huge programme, a big technical piece of work and millions of pounds spent. It is also about making the changes to services so that when we move into new facilities, we are delivering the new models of care that Freddie described. So I don't think there's a direct relationship between the CQC report and the right solution, but it's helpful that we are moving in, positive steps forward in terms of our CQC rating.
Thank you. And I have a question which might be one for Freddie, and it is about the separation of planned and emergency care. And the question is, do you mean this should be on separate sites? And the person asking the question has said, for example, they're not aware that this is in the plans for the new hospital at Harlow. And do you have any other examples for how this works anywhere else? And any other, the question is, do you have examples from the other 4 government priority trusts in this group for immediate extra funding? But maybe, Freddie, if you can address the separation of planned and emergency care, that would be great. Thank you.
Okay. So, well, I don't think it has to be on separate sites, the segregation of what we tend to call hot and cold. One of the key component is, though, that you don't contaminate your elective site all the time with emergency cases just as an overflow facility, because that's effectively what happens at the moment. As soon as the hospital gets a bit hot, elective capacity goes down, and that's exactly what's happened with the coronavirus, to the extent that effectively all elective surgery has ceased at the moment. a very good example of where it works very well would be Guy's and St Thomas's, which is obviously the Hughes Great Trust in London, where Guy's is effectively an elective centre. There's no emergency centre or A&E at Guy's. It is all through St Thomas's. And if you wanted to see an example of an elective care centre there, then the Guy's Hospital, you can actually YouTube it and see how it works from a patient perspective and a flow, and that's really a sort of basis that I'm trying to deliver for my own specialty of urology. So that's a very good example. But coming back to the question, does it have to be on separate sites? No, but you have to have very strict rules which are quite difficult to enforce when it's all on the same site, that you don't contaminate your elective centre with your emergency patients.
Thank you. And I have a question about the site review, and I wonder, Esther, if you might talk to us about when the detail, well, what the site review is and when the detail in it will be public.
Looks like Esther's having difficulty unmuting.
Okay. Please bear with us. This is the first time that we've done this.
Thank you, Louise. So, as Helen mentioned, we have external experts who are completing the site review for us. They are looking at a handful of sites, and they will really be providing us a view as to whether sites are viable, what the planning implications are, what the infrastructure implications are, and to help us inform our evaluation of options. So that piece of work is already underway. And we would expect that we will get some outcomes of that in a couple of months' time. So it's progressed. We have a briefer scope, so we're happy that that's something that we could share so that people would have more information should they like to see it.
Thank
So
you.
I'll just come in on that one briefly as well, Esther, which is to say that clearly we're going to need the output from that piece of work before we finalise our long list to short list decision making process. So we're working to get that report completed, or hoping that the team who are doing it, or we've asked them to ensure that they provide that to us in August, so that it can feed into the final piece of work to appraise the long list and reach the short list decision. And it is clearly a very important piece of the jigsaw puzzle.
Thank you, Helen and Esther. Helen, can I ask you to address a question that's come in about the shortcomings of the site or the buildings as they currently are at Watford, and you know how we're able to consider a redevelopment on this site given the state of some of the infrastructure that we've got here already?
Yes, so I think we would all recognise the challenges in the hospital as it currently stands, but as we shared with you at previous stages of this process and at the strategic outline case stage, there is quite a lot of flexibility within the Watford site and the adjacent Watford Riverwell development that gives us flexibility to build a substantial new clinical block, and to do that whilst we maintain the operation of the current hospital facilities. The detailed work on that is still to be done. So through this long list process, the estates and technical team are working up in a bit more detail both the previous option that we looked at, the £350 million option that retains Princess Michael of Kent, but also what could it look like if we went for an option that replaced the main clinical block, and how would that look, and what aspects of the current buildings would we retain in that option versus what would be in a new build. The preliminary work has indicated that it is there is a viable option to effectively rebuild the majority of the clinical service provision on potentially the existing car park land. But that is detailed work, so a degree of detail will be done between now and the shortlisting decision, and then for any options that get carried forward into the shortlist, another level of detailed work will be undertaken through the shortlist to preferred option stage of the process. But overall, there is a significant flexibility within the site. And again, we can make comparisons to elsewhere, and we can say that actually we're in a relatively fortunate position in terms of the Watford General site in the flexibility we've got. And if you want to see what challenging development looks like but can be achieved, the hospital in Brighton is doing a large redevelopment on their existing site at the current time. And to go back to the PAH comparison, and one of the drivers for them in terms of looking at a new site option is that their site is really, really constrained, and they've got very little flexibility to build new facilities alongside the existing hospital.
Thank you. This is a sort of linked question, which might be also for you, Helen, or Esther might want to come in. But we've been asked how we can future-proof our sites for all the advances that we know of, and even those that we don't know about. And the questioner has mentioned genomics and holistic care, and I guess in our recent experience we would also add digital into that. So perhaps
so I'm actually going to ask Esther.
Thank you.
Esther, do you want to kick this one off for us?
Yeah, and that's quite a broad-ranging question, and I think there's a degree to which none of us know for sure what we're going to need in 30 years' time. We know things will be very different, we just don't necessarily know how. But there are things that we can definitely do as part of the building infrastructure to be able to add on and to be flexible. So things like making sure that we have room to build on to any buildings that we create. So Chase Farm, their new hospital is a really good example. They've built in the heating risers and the lift shaft so that they could add another floor into the future. And also looking at the any sites, making sure that there is land around any new building so that it gives us maximum options. Within the buildings themselves, when it comes to looking at how we can be flexible, I think the fact that we will be building to new hospital guidelines, the rooms, the spaces will be much bigger. It does give you greater flexibility for future if you've just fundamentally got more room than we have. Digital technology, we know that we need to make better use of that. There are other countries where they're looking at things like drones for deliveries around the hospital. There are all manner of things that will be coming for digital, and I think generally a good rule is to try to spec to the future as far as you possibly can when you're looking at digital infrastructure. There are places that we can learn from. So as part of the work that we're doing with our frontline staff, we're very much inviting people to say where else should we look to, both within the UK and worldwide, where they are doing innovative things and where there's things that can help us look way beyond the facilities that we have at the moment and help us get a good perspective as to what the future possibilities are.
Thank you. I've also had questions about the presentation and the recording of tonight's meeting. So we will make sure that the recording is up on our website by midday tomorrow, and it will also have notes alongside it. So like very similar to the what we actually said. So if you want to look at it as a set of slides with a printout, we will endeavour to make that available by midday tomorrow. And I've also been asked a really good question about how we will engage with people who don't have the technology to use Zoom or Teams or all the other digital technology that so many people are using now. We have got increasingly good links through community networks with help from the local councils, through volunteering networks and faith groups. So we are reaching out via other means to make sure that people can read information that we send them. We also have translation services, so we are trying as best we can to make all the information accessible to everyone, so that we do have a really representative group of people working alongside us as we go through this process. I just wanted to also say that thank you for the suggestion about having the slides running throughout the break. We will definitely do that tomorrow, so that during the time when some of you are submitting questions, you could have been re-looking at the presentation. So we will do that, and you will definitely have it before you get stuck into your homework. So apologies, it is the first time, but we've learnt a lot. So thank you for the constructive comments. And we have had one or two people wanting to ask questions about the choice that we might make about Watford as the site for redevelopment versus a greenfield site. And although we're not at that stage in the process, I wondered, Helen, if you might want to say when we would look at that option, if that's okay.
So effectively, that's the work that we're doing between now and September. And we will be talking to you more about the long list process at the next session. There is an expected way to do this. There's something called a long list generator. We didn't use it at SOC stage because this is new guidance effectively in the Green Book. So we'll be using the long list generator. We'll introduce that to you in the next session. And then the third session that we've got planned in this current kind of 3-session run, we'll look at the appraisal of the long list framework and what does that mean. I know that inclusion or not inclusion of a new hospital on a new site will be a very hot topic through that process. I think, and we will share with you what information we're using and what consideration we give to that. People will have opportunities to input. I think it's fair to say that we do understand, you know, there's quite a strong body of opinion in favour of a new hospital on a new site, and we will be giving it due consideration through this process. But I think I do also need to just go back to the regulator dialogue around, you know, we haven't got a blank check at the moment, so we do need to be confident in the relative costings of options to enable us to make a shortlist decision, and timeline to deliver is also very important. Now, HIP1 hospitals have been asked to deliver by 2025. Now, that is a very tight timeline. There may be a bit of flexibility in that, but clearly the Department of Health, the Treasury, the Prime Minister are all keen to see progress. I think more importantly for us, we are never more aware really about how our current estate is not fit for purpose and is really challenging to deliver care from. So we do want to find solutions that can be delivered as quickly as feasible. So those will be key factors through the long list appraisal. But at this point in time, absolutely, green new site options will be considered as part of that process.
Thank you. There was just one quick question, Helen, I think before we wrap up, which is a concern that somebody's raised about traffic. So perhaps you might touch on the new road and its impact for us here at the Watford General site.
Yes, so this is an issue that's come up in the past. It's obviously feeling quite different at the moment because the roads are so quiet, although they're getting busier as time goes on. The new road has improved access to the hospital, both for ambulances but also for visitors to the hospital, and it has eased congestion on the Vicarage Road. We know that there's still significant challenges with car parking when you get to the Watford site. So we've got plans in process to develop a multi-storey car park on this site. That's required regardless of any decision about the long-term solution for our hospitals, because the current arrangements are not able to be maintained for the medium term. So access is a factor, but our experience is that the new road has improved access to the hospital.
Thank you very much. And other questions were about links. So we've mentioned things like Green Book, so we can make sure that we put a link to the Green Book on our website. I just wanted to remind you that our deadline for your feedback, please, is midday on Wednesday. We will endeavour to put on as much information as we can onto our website so that you can look at that, and please keep checking back. We will use your questions to update a frequently asked questions sheet, so we will keep you updated as best we can. You've asked for more detail on the information that we've shared with you tonight from regulators. We will put that on our website as soon as we are able to. And that really is it from us. We're at 7:30. I want to thank you on behalf of everyone that you've heard from this evening for joining us on this hot, sticky evening. We will be sending you a questionnaire. We've had feedback from you already about things that have worked and things that haven't worked. Please keep that coming. We want to make this as good for you as we can. So do share your feedback with us, all sorts, constructive, whatever. It's good for us to hear it, and we will be in touch with you again very soon. Thank you very much.